Allegedly, we'll have a bumper crop of heroin from Afghanistan. And apparently there's been a diversification of Afghanistan where they're looking now at amphetamines and particularly crystal meth. There's a lot of people out there who've used substances and never became addicted to them because they used them recreationally. I had a patient who said to me, I'm not a drug user, and they liked steroids a lot. When you looked at them, they looked absolutely amazing, to give them credit. They had the body that a lot of men want. They didn't drink. When you asked other things, they used a lot of coke. Ephedrine, caffeine and aspirin is a fat burner that would be used classically by a lot of steroid users.
What are your thoughts on codeine?
It's a very unelegant drug for pain. To me, codeine, it's kind of a dirty opioid in some ways.
Welcome to my podcast, The Laura Dowling Experience. Many of you will know me from my Instagram page at Fabulous Pharmacist, where I love to shine a light on topics that people normally shy away from. Today I spoke with Dr. Denis O'Driscoll. Denis is a pharmacist who worked in addiction services for 22 years. We discussed the methadone programme. We discussed all manner of drug misuse, from steroids to heroin, codeine to pregabalin. We covered it all. We discussed what legalisation of cannabis might look like in Ireland. We asked the question, should codeine be prescription only? And we also discussed the misuse of prescription medications such as benzodiazepines and sedatives. There is something in this podcast for everyone, I guarantee you. To support the Laura Dowling Experience, please check out my sponsors in the podcast notes below. Enjoy the show. Denis, welcome.
Thank you, Laura. Thanks for having me.
So happy to have you on the pod.
Thank you.
Denis, you are a pharmacist.
Correct.
As well as being a friend. So
Yes,
I'm
correct.
really happy that you're here and that we can have a chat. And what I really want to talk to you about is addiction and addiction in Ireland, because that is really your area of expertise. But first of all, can we have a little talk about how you got into pharmacy and how you did your PhD?
Why? The big
And
why.
I know. And then the work that you did in the HSE.
Okay, so why I did pharmacy. Been asked this a couple of times and I can't actually figure it out. But remember when I went to do pharmacy, it was the 80s, and the CEO form, the only job that you could be guaranteed after doing a course was pharmacy, written in the CEO form. So I went, yeah, maybe I'd be interested in pharmacy, but I was also interested in medicine. But I had a grand-aunt who was a herbalist. So there was always this interest in the family with natural remedies and herbs, and she had a copybook that we have at home with all her like little recipes in it. And so for me, it was either going to be pharmacy, medicine or botany. And then I had way down the very bottom, Japanese and marketing in DCU at the time, which is a complete anomaly. But I thought I'd like to go live in Japan. When I did pharmacy, I arrived in on my first day. And I remember being in there the first couple of months kind of going, oh no, I think I'm going to do medicine. And then I went, oh no, I'll just, I'll see what this is like and stick it out. I enjoyed pharmacy. I have to admit that when I went in, I was one of these people who hadn't done chemistry in my leaving cert. I'd done the wonderful combination of physics, chemistry, and suddenly you were landed into this chemistry. And it was, I have to admit, my first year chemistry was like a complete and utter, I would say, I struggled really badly for it.
Oh my goodness,
really
it is
badly.
disastrous for someone that hasn't done chemistry before.
So, but all I can say is by the end of, in my fourth year, I did really well in the medicinal chemistry side. So for me, it was like a learning throughout my career in pharmacy. While I was there in pharmacy, I did other things like everyone does. I joined, obviously, the Students' Society. I became part of the International Federation for Pharmacy Students, so that allowed me to travel to South Africa to represent Ireland 1 year at a conference. Yeah, and the year before I'd gone to Zimbabwe as an exchange student and worked in the Ministry of Health and the WHO. So I did a lot of pharmacy things that weren't, how now they're recognised throughout your career when you're doing your undergraduate now, when you do these pieces that they're seen as really positive steps. That I didn't work in a pharmacy, but I worked doing pharmacy things. So in Zim, I worked on an essential drugs list for the country with the Ministry of Health and the WHO.
Is that while you were in college?
Yeah. In my third year in college. So I was given classification. Mine was gastrointestinal, and we had to do an essential drug list, which is very simple. You have a drug for a condition, and you list your first one, second one, third one, fourth one. And at the time, believe it or not, PPIs were just coming into being, and they were so expensive at the time, and they had to be bottom of the list because of the costs associated with
PPIs, by the way, guys, are proton pump inhibitors, and they stop the acid in your stomach being produced basically at the very source.
And when they came in first, they were so expensive.
Yeah.
So for a country like Zimbabwe, were using different products, and that's how they were listed. And then I worked with a Danish lady with the WHO on HIV for women who were pregnant. And at the time, the village we were looking after outside Harare, 1 in 2 childbearing women were HIV positive.
Wow.
So it was, and that was really interesting. Like HIV in Africa was completely different to the way it was being looked after here, for example. And then South Africa was a great experience at that International Students' Federation. And then I did my pre-reg, 6 months in industry in antigen, gone with the wind now, which was down in Roscrea, and 6 months with an amazing woman out in Glasgow, who's passed away, Anne-Marie Quinlan Burke, an amazing woman. And then I didn't know what I wanted to be when I grew up. So
Do you still not know what you want to be?
So then I decided, maybe I'll go back and do medicine. And then I went, I don't know if I can phase into 10 years X.
Yeah.
And what was I interested in? I was particularly interested in psychiatry. And then I went, and that's why I said, no, I'll do a PhD. I liked pharmaceutics, and I thought after my stint in industry that's where I'd end up. So I did pharmaceutics with Denis O'Driscoll, and we did cell culture technology and use of cyclodextrins as novel transporters, blah, blah, blah. Wrote up my thesis.
You make it sound so
it was
interesting.
I had a great time. My PhD years were fantastic. Dublin was starting to boom.
Were you locuming then to...
So what happened was that at the time, which leads into why I ended up in the addiction service for so long, at the time, the methadone protocol was being introduced to align the way that people could access treatment for addiction, for heroin addiction. Prior to that, there was no central treatment list. There were certain prescribers that had hundreds of people just attending them. There was no supervision of methadone in a pharmacy. And like I remember working in a pharmacy in the South Inner City, and this guy used to come in once a week, and at the time it used to be Phyceptone. And he used to get like 2 large bottles of Phyceptone, 2 litres, 2.5 litres each. And I never knew if he took it. It was for another person. He used to collect it for another person. So we never knew who was on it. So then the methadone protocol was introduced.
Okay, so prior to the methadone protocol, because this is all before I qualified.
Yeah.
It was just given out like a normal drug?
It was just like given out like a normal drug. There was no supervision. There was no people knowing that. So, for example, Laura Dowling could attend 6 doctors and get methadone from all of those doctors without actually each doctor knowing that you actually were accessing treatment elsewhere.
And this was back in the 90s, was it? When the heroin situation in Dublin was...
So that kind of exploded. Like you could, the time of Veronica Guerin's murder around that time, the heroin issue in Dublin had exploded. But people need to remember that the treatment, so bringing in of treatment like methadone and buprenorphine, the whole ideology behind it is that it was the prevention of viral transmission. And people have that, so it was always brought in as a harm reduction measure rather than a treatment measure. Now, I know that it's moved into that.
Can you just explain that? What the prevention of viral transmission?
So the prevention of viral transmission. So at the time, like in kind of the mid to late 90s, there was a huge explosion of hepatitis B amongst certain people who use drugs within Dublin. And that was creating huge issues. And then HIV started hitting, and it was hitting that population. So to stop people transmitting the virus by sharing needles and works, they brought in, methadone was brought in for more treatment options in order to look after those patients. So by bringing people into treatment, the whole idea was that they'd stop using works or sharing needles and works, and therefore you'd stop the transmission of viruses.
So it wasn't necessarily to get them off the drugs completely. It was
a lot of the early programs were like short interventions. They were never like long-term intervention. It was seen like when I was asked to. When I was doing a PhD, the addiction services started opening up in Dublin. So I remember going to the North Inner City to work. In one of the services over there, being told by the manager of the service saying, "Oh, we'll only need you for about 6 months, and we should have all this sorted by then." So that was around 1996-7.
How long were you there for?
22 years later, like.
Okay.
So like, it was like. The idea was that it would be a short, sharp treatment, because people forget that methadone and interventions around treatment were actually in Jervis Street in the late 70s, where now the Jervis Street shopping centre is. There was a hospital there called Jervis Street Hospital.
Okay.
So we had treatment was offered, but it was short term. So it was always like you started on a dose, maybe 40 to 50 mils, and were reduced downwards and off. And it was for certain cohorts and interventions. So in pregnancy, it was used in youth if they came forward for treatment. And then the basis of the whole service came about with the introduction of the original methadone protocol, where they made sure under law that it was much tighter. Because what was happening is that at the time, if people may not remember, but the EU had butter mountains and milk lakes in Europe with all the excess. It was a bit like in Dublin, there was a Fiseptone lake that there was so much of it out there that we had to take it back. And also,
Can you just explain, sorry, what the difference between Fiseptone and methadone is?
Okay, so Fiseptone was, so you hear people referring to methadone as Fi, and it comes from that. So Fiseptone was originally linked to sugar. Containing product, and less strong than current methadone. So it wasn't 1 milligram per mil. It was, I think, 2.5 milligrams in every 5 mils. So you needed a higher volume of Fiseptone versus methadone today. So when they changed the protocol, when the protocol was introduced, Fiseptone was removed off the market, and only methadone sugar-free was left on the market.
And was there a reason why it was sugar-free?
To stop the damage to the teeth. The thing is, methadone itself can damage your teeth because it's acidic. And you must remember, taking an opioid, any opioid, that it does reduce your saliva production. We all need to remember that saliva does protect your teeth. So by having saliva in your mouth, it protects your teeth. But if you're taking something like methadone, and what happens then is that the methadone being acidic attacks the teeth, and if there's sugar in it, it's even more damage to the teeth.
And by opioids, we mean anything with an opioid type
drug. So opioids for me is everything across. So people refer sometimes saying opiates. Opiates refer usually to naturally occurring substances such as opium, morphine, heroin, technically,
Okay.
Opioids refer to all the ones that are manufactured. So methadone is a complete manufactured drug. It was the wonderful Hushed invented it around 1944 because they couldn't access raw opium to create morphine and heroin for treatment of pain. So they created this new substance.
Okay.
So that's where it came about as a synthetic substance. So opioids cover all kind of synthetics, buprenorphine, methadone.
Codeine?
Codeine is a naturally occurring one. So it covers all of them by saying opioids rather than opiates. It's a nuance, Laura. It's me being pedantic as well. Yeah.
Oh yeah, no, but I want the people that are listening to understand too, because they don't necessarily have a pharmacist background or the medical background. Can you just explain why people can become addicted or dependent on opioids or opiates? Okay,
that's a good question. So if you talk to people who use drugs and when they're coming for treatment, one of my question was, they'd often say the first time I tried heroin, it wasn't a great experience because opiates classically cause nausea, cause constipation, can give you skin rash and itchiness under your skin, particularly heroin. But equally, what they said was that after one or two occasions that it felt nicer, so they were getting a lovely rush. But also what it was doing was that what they were getting, if you remember, at the time when the heroin crisis, there was a huge economic depression in the country. So what heroin does, or any opioid will do, is that it almost costs you in kind of a kind of, you go into a kind of sleep state and relaxed state and
it feels like
calming.
A warm hug is what
Yes,
I've heard.
A warm hug. Yeah. Some people talk about this lovely rush that goes through their body, like a warm, tingling sensation through their tummy when they use heroin, and it makes them feel good.
Okay.
The issue with all these drugs is that using them regularly and you develop a dependence.
And isn't that because there's opioid receptors in
Correct.
the body?
Yeah,
so we
there's-
naturally have them.
We have them because we have our own endorphins. So after having a coffee, chocolate, sex, running, we release our own endorphins. That's why we feel really good when we do something like that. It makes you feel positive about yourself and you feel energized and you feel like, oh, this is great. And equally with heroin, when it hits the opioid receptors, they fill the receptors and obviously you're going to feel calm, relaxed, kind of, as you said, that warm. I like to refer to it as a little pillow hug that's warmed up, that you feel nice and warm and cozy. And equally, it takes you out of a reality into a different mind state.
Okay.
So there's that as well. Like, but talking to patients, for me, talking to my patients, our patients of services, are the best person to tell you how it makes them feel. And a lot of them would say it just takes you away from the reality of what's going on around you. Makes it easier to live. So
Which
yeah.
is sad to hear.
Yeah,
isn't
you
it?
know, but like this is why when people talk about, you know, that it doesn't occur here where I live because I live in a lovely area, but addiction doesn't recognise class boundaries, doesn't recognise education boundaries. In my time, I've come across people who are professionals down to non-professional people who have addiction issues.
Yeah.
Each one obviously will have different supports to get them through it. So what you find is those who have really good support surrounding them often will be more motivated maybe to look at how I can change that pattern of addiction.
What do you mean by support?
So family support is really important. Often counselling support to attend counselling services or psychotherapeutic intervention services, particularly CBT, cognitive behavioural therapy. That kind of support. They also are maybe in an environment where they're less exposed to active drug use. So I always give an example of how difficult it must be for people who have taken the step to go into a detoxification unit, and when they leave after successfully detoxifying, they're going back to their own communities, where in some of their own communities, their next door neighbour could be the active drug dealer. And suddenly they're back exposed to that. So it's really hard for them that resilience needs to be built in. And it's very hard sometimes to keep that resilience up.
But sure, isn't it the case that they would leave the detoxification centre, go back home and be offered free drugs by the dealer because the dealer knows it's happened?
Yeah, I used to have a patient and really nice person, really nice person, living in Dublin, and she remained on 2 mils of methadone a day, because
2 mils is tiny.
Well, 2 mils is non-therapeutic.
They're actually not getting anything from
No.
it. That's just almost like as if it's a crutch or something.
Well, she was using it because where she lived, if they knew, as she used the word clean, which is a word I don't particularly like, clean, that they would ask her to test the drugs to see how good the quality was. So that's why she always remained. So her excuse for not being that person was, oh, I'm still on the programme.
Okay.
So then they go, oh, it's pointless, you trying this for us.
And can a person stay on the programme forever and ever?
If that's what they want. It
Okay.
should always be person-centred. So for me, a really big learning piece within the addiction services was that at one stage we were creating, the same kind of suit for everyone to wear, regardless of size, regardless of where you came from. So you got X amount, Y amount, and Z amount. There was no kind of holistic approach. Whereas as over time, as the services kind of got used to the whole thing, because you must remember that when the services were created, people were new to these services. Like, they'd worked with people with addiction issues, but they were new. Like, I remember the first time we went up to 100 mils of methadone for someone. We had a massive multidisciplinary team meeting about the whole idea. And the reason, like, now when you look back, you kind of go, why did we need to do all that? It was the fear of, was that too much to give someone? But in actual fact, what it did was it allowed the person to actually to stabilise properly rather than continuously dabbling. So they didn't dabble anymore. They were on a proper dose so it'd be like us under treating a diabetic with, oh, I don't want to give him that amount of metformin, which is used for diabetes. I'll only give him 500 because, it's better than nothing, but it would still not control their sugar levels.
Okay.
So we moved very much and then with HIV treatment, that created huge difficulties with regards to drug interactions and doses of methadone increasing significantly because of the drug interactions.
Tell me about them.
So the classic one was Fenerase and ritonavir, which are two drugs. Ritonavir...
These are drugs for HIV.
Ritonavir is a fantastic drug because in vitro, when they did the tests on it, there was no DDI, which was great.
What's
but
a DDI?
Drug-drug interaction. Sorry, Laura. There was no drug-drug interaction. So that was great. Everyone fantastic. But then when it was done in the person, there was a massive reduction in methadone because what had happened was that they hadn't noted that what ritonavir was doing was displacing methadone off where it bound on protein sites in the body.
Okay.
And then the methadone was being washed through the liver and being metabolized quickly. So there was a 50% reduction in the effectiveness of methadone when they were on ritonavir. So let's say you're on 100 mils, that means I had to increase your methadone now to 150 to account for the ritonavir dose.
Okay.
And then if there was another drug in there that caused a drug interaction, and it was always to do with the cytochrome P450, which is a liver enzyme which breaks down a lot of drugs, you had to increase the methadone dose even further to account for those. But equally, if they came off those drugs, because at the time, you must remember, there was a lot of drugs coming onto the market new. Yeah. So people were often changing regimes in order to get the right regimen for them on for their HIV. You'd also have to drop the dose back down because you could actually poison someone.
And how did you find out about the fact that the drug interactions were happening? Because there is a sense that if a drug user or a methadone program person was coming in saying, "Oh, I'm not getting the same high," or "I feel I need to use more," that they may just be looking for more drugs. How did that come about? Was there was the ritonavir one was interesting because we knew that it would affect the protein, the displacement. But we didn't think it would affect it as badly as that from a lot of the research and the clinical trials. So the original in-field studies from the States demonstrated that there was a difficulty with it with certain drugs going through cytochrome P450. And that was the biggest problem with methadone. We all knew it was cytochrome P450. Okay. And then a paper was issued, I think, from the States. I could be wrong, it could have been Europe, where they said it was at least 50%. So we would up the dose. Remember, conservatively, because with methadone you're very conservative in dose induction because of the risks of poisoning someone with methadone. And if you do poison someone with methadone, what happens to them?
They go into a deep stupor sleep and may overdose.
And what does overdose look like? What are the side effects?
So the classic signs of overdose, particularly in an opioid, is difficulty breathing. So they have this thing called agonal breathing where they're kind of almost
okay,
or they're not breathing at all.
Okay.
You might get a bluish tinge because they're becoming hypoxic because they're not circulating enough oxygen around the body. So they get a blue tinge to the nail beds and to the lips. Pulse rate will drop. And breathing will, if they're breathing drops below 10 breaths per minute.
Okay.
So it's an emergency at that point.
Yeah.
Being on when you're on methadone, there's a catch-22 with methadone treatment. So being inducted onto a methadone program is a very dangerous time for anyone who uses drugs, because what's happening at that point in time is everyone has this thing that, Dennis, you know exactly how much they're taking. I don't. I can't tell how much heroin somebody's using. We take a urine sample. Yes, we check the urine sample for the metabolites of heroin to confirm, yes, you use heroin. But I can't tell how much heroin they've used. It's a conversation I'll have with the patient where you do an assessment, kind of going, how many bags do you use? What's your regularity of use? Do you inject? Do you smoke? You might look for some track marks. How often do you inject? So that gives you an idea of kind of how much heroin they're using on a daily basis.
You don't even know how pure the heroin is.
Not at all, no.
So the purer it is, the more toxic it will be.
Well, obviously you'll have a higher concentration of drug in order, and often you hear people talking about strong heroin and is that it's strong heroin, or is it not heroin and another opioid be mixed in?
Okay. And what other opioids could be mixed in?
Oh, the one that's causing huge problem in the States is obviously the fentanyls. Mm-hmm. So they're highly potent, highly active opioids really, really strong versus like some of them are anywhere from like 50 to 1,000 times more potent than morphine. So
Have they been made in labs over there by the underbelly, or is it just
fentanyl is available as a prescription drug
Yeah.
here. So yeah, a lot of the interesting fentanyls, so the ones that are on the black market, are manufactured in labs. Yeah,
okay?
because a lot of them were. You can go into patent laws and find all these drugs that are made that never made it to market because there was a side effect noted that was inappropriate and not safe for human use. But once the patent is gone, these are available that you can manufacture away to your heart's content.
But are pharmacy or like big pharma manufacturing them, or is it just like people
No, illicit
in the black
labs,
Okay, yeah.
Yeah, illicit
And is-
labs.
The issue with fentanyl overdose in America never quite hit Ireland. Sure didn't.
As yet.
Are you worried
Well,
that it could?
What I always recommend if people are interested is that to go onto the website, the EMCDDA, which is like the European Monitoring Commission for Drug and Drug Dependency.
Okay.
It's a very interesting website. It's based in Lisbon. And what they do is they do country profiles of all the countries. So for example, Ireland would be what's the most common drug of use, what in overdose statistics, what do we look like? Do we have treatment? Do we have needle exchange? Do we have overdose prevention programs? So it lists countries with each of their profiles. What's interesting is Estonia, 2016-17 was absolutely destroyed with fentanyl derivative known as fluorofentanyl, and the overdose rates there peaked in that country because of it.
How do they take the fentanyl?
Some smoke, some inject.
Okay.
Can be, it's an easy enough. The biggest issue with it is that sometimes if it came into the market, the biggest problem with it is that the potency of it may take people who use drugs off guard, because they will use the same amount they'd normally use for heroin, and suddenly now they've used too much and they could overdose quite quickly. Plus, you must remember fentanyl peaks. If you're to look at it in the body, it peaks much more rapidly.
Dennis is doing a lot of hand movements, guys, but anyone that watches the YouTube video will see.
So when it peaks, what happens is that it peaks much more rapidly, and trying to get to someone for an intervention of an accidental overdose is much more
difficult.
You need to be much more rapid, and it binds much stronger to receptors, so you need a lot more naloxone to get it off in order to get people back breathing.
Okay.
So, and then there's newer products coming through that we've seen. They're called isobutadiene, which is another opioid derivative, which is even stronger than some of the fentanyls.
Jesus.
So the
Christ.
biggest issue here is that the drug markets are amazing. The illicit drug markets are amazing, the way that they can modify so quickly. And the other thing we keep forgetting is that allegedly we'll have a bumper crop of heroin from Afghanistan. And apparently there's been a diversification of Afghanistan, where they're looking now at amphetamines and particularly crystal meth. So yeah, it'll be interesting.
Oh my goodness. Can you just explain to people about naloxone, because you did mention it, and
Okay.
what it does?
So, thank you. So naloxone, So when I was in the addiction services, around 2013, 14, 15, actually I should go back further, because you may as well tell people how old I am.
Give the full story.
So in 2005, this is where I believe we need to do intervention around overdose prevention. 2005.
Yes.
Went to London to John Strang, who's I would refer to him as the founding father of overdose prevention, particularly in UK, Northern Ireland. He works in the Maudsley. He's known for a lot of his interventions around for people who use drugs, always looking at how to reduce harm if they want to use drugs. So that was my philosophy, was always there, that if you want to use drugs, that's your choice. I'm just here to ensure that you do it safely and you don't die. If you want, that's the bottom line of where, in harm reduction, where I would go.
I would agree with you.
So needle exchange was in Ireland. So we were giving clean, our fresh works, as I like to refer to them. And I worked with a guy who worked a lot in overdose prevention, Tim Bingham, and we always used to use the word fresh works rather than saying clean.
Yeah.
So they're fresh. So you get a much. So we'd say to people, make sure you get fresh works, because then you know that what you're going to do is that the needle is much sharper, so it's a much more pleasurable experience. Like in essence, you're almost encouraging people to use, people would say, in harm reduction, but you're not really. You're just trying to make sure that they don't reuse old needles, because if the blunt, they do get blunt after first use.
Oh my goodness! And even the thought of that.
And blunt needle going into veins damages the veins more. So you want it to be fresh work, so it's a nice sharp incision with less damage. So anyway, in 2005 I went to London to learn about overdose prevention. I thought this was my best hobby horse ever, and happily skipped over. Amazing training program, all about the words ABCN will never leave me. A for ambulance, always make sure you call an ambulance, call for help. B, check if they're breathing, not breathing. C, if they're breathing, you put them in recovery. I appreciate R is recovery, but C is in recovery. If they are, if they're not breathing, start CPR, and then N for naloxone.
Okay.
So that was the mantra: ABCN, ABCN, ABCN.
Okay.
So in 2005, and I came back from that really like, this is the way we need to be giving naloxone to all our patients to make sure that they know how to use the product. But there was, like everything in life, there's always a lot of speed bumps to get over.
Or resistance.
I like to use the word speed bumps, and ways to move around the system. So around what came about to allow naloxone to be much more widely available was the emergency drugs legislation, when pharmacists were being permitted to use epinephrine auto-injectors without the need for a prescription in an emergency.
But how long, like, when was that introduced?
2015.
So it's still like, it's...
Yeah, 10 years later.
Yeah.
The way I looked at this is that in 2000, just to go back even further, on my 30th birthday, I went to North Wales and Liverpool to look at pharmacy needle exchange, and didn't get it in till 2011, 2012.
But we're still not doing an awful lot of pharmacy needle exchange.
In the rural parts of Ireland, there's much more pharmacy needle exchange. It was considered in Dublin. You had a lot of huge exchanges already in existence, run by the voluntary sector, that really was there a need for pharmacy to do needle exchange in Dublin.
Okay.
That was the thinking at the time. Now, things changed, and maybe a further review needs to be done on that. But the only thing, the way, again, with everything, is with the needle exchange in pharmacy, is that people go, oh, I want... a blue needle, which is a 21 gauge, am I right?
Fat.
Yeah, 1.5 inch. I want that because I want to do groin injecting.
Okay.
In pharmacy, we wouldn't offer that kind of a pick and mix service, as you'd call it. This is more like, in pharmacy, you get a pack made up with a certain needle type in it, and some people who use drugs don't like those needle types.
Okay.
So we would be seen as the bottom level of the rung in needle exchange, that we offer a service, but it's not necessarily a bespoke service. Now, to give credit to the needle exchange program, they have become more bespoke, depending on who's coming looking for the product. So tanning injectors, for example, are very specific injectors. So they need a specific needle for a subcut injection, but they don't need things like product to break heroin down. They don't need spoons to mix their heroin with. So you have a different we've developed a different needle pack for them. Steroid injectors, again, are a different cohort who need a different type of needle type versus somebody who is using a person who injects heroin or cocaine or whatever. They would require a different type of needle and type of product. Okay. So it has diversified to allow you to access for certain cohorts, and some of those cohorts are quite underground in the sense that there's not a lot of them coming forward. So when you find that cohort, we have one pharmacy in particular who has a high cohort of tanning injectors. So he doesn't really want the one for heroin users, he just wants the tanning one. So they can order kind of a bespoke, but then that's the service they offer.
And just to note, the tanning injectors, this is not legal either.
No.
Yeah.
No.
So, but this is just people.
So this is a drug that you can buy online.
Yeah.
If you look at the ads for it, it makes you look really beautiful.
Okay.
You can develop a beautiful...
Could it make you and I look really beautiful?
We don't need that, Laura. But it makes you you go brown because of it.
Okay.
You could develop a tan. You have to initiate the tan by going on a sunbed.
Okay.
But the problem is that depending on the way you get it and the way it's manufactured, you might get it in pre-filled needles, but I don't know what water or anything they've used to make it up. So it could be dirty water, so you get an infection in your skin because you're injecting it. Sometimes they get a variation, obviously, in strength, that they go a beautiful Oompa Loompa colour rather than nice brown, and sometimes there's a green tinge.
And is this something that's actually quite popular?
Yeah.
Jesus.
Amongst certain cohorts, yeah.
Okay.
Yeah, because it's very instant. You don't need to go on sunbeds all the time. You don't need to, use fake tan, any of that. You don't need to go on a sun holiday, but you always look glowing orange.
Fabulous.
Yeah.
In Canada, there was a fentanyl issue, and all pharmacies were given naloxone.
Yeah.
So literally they could run out and help someone on the street. Now, obviously, because the fentanyl crisis hasn't come here, like what you say, yet, or hopefully it won't, do you see that?
So, I go back to 2015. The legislation was brought in under SI 449. I highly recommend all your viewers to read it cover to cover. It's an amazing piece of legislation.
I'd say it wouldn't put you to sleep now.
No, it's amazing. And to give credit where credit is due, the naloxone was allowed to be put into that legislation as a drug for emergency use by pharmacists. Because at the time we were agitating for it when I was in the HSE, but equally had really good political back to it. So at the time, Leo Varadkar was the Minister for Health, and to give him credit, he did support it. He saw the advantage of putting it into the legislation.
Okay.
So then we had to demonstrate that naloxone will save lives in Ireland, which is kind of like, you kind of go, really? Worldwide, it saves lives for opioid overdose prevention. So we did a naloxone demonstration study. I hate the word pilot because for me, pilots always end up on a shelf and never move forward. So demonstration means that you've demonstrated works, now move it on.
Yeah.
So we did a demonstration study, and in that time we had, we ran it from, let me think now, we ran it from June to kind of September. I had only funding for 600 products. So very low budget.
Okay.
And like a very low budget movie was being made here. And what I did do was we targeted hard to reach populations and really populations within addiction services that may not come forward for treatment, that attended low threshold services like needle exchanges or food, homeless shelters. People who didn't come into treatment. So we didn't see. So, and in that time, we know naloxone had been used 3 times and successfully somebody was brought out of an overdose.
Okay.
So we now had evidence to say, yes, it can be used by lay people who are appropriately trained and by service users themselves. So people who use drugs themselves that could be trained in how to use it and quite successfully use it on their peers.
And is it easy to use? They just inject it?
Well, in 2017, a nasal product came onto the market here.
Okay.
And the nasal product is a really easy squirt up the nose. The injection is a little more technical, but the injection is into the thigh, a really nice big heavy muscle to be able to get it into, and you have 5 doses. So the program has been running. It's been expanding, and the wonderful thing is to give credit to, I think it was Catherine Byrne at the time, who was the junior minister for drugs at the time. She got a piece put into the National Drug Strategy. So by being part of a National Drug Strategy now means that that's the vision, that it has to be available. So the vision in that was that the wider availability of naloxone to people who use drugs, their families and loved ones and communities, which literally means almost like AEDs, it should be everywhere.
Okay.
So as time progressed...
AEDs being?
Automated defibrillator machines.
He's looking at me and rolling his eyes. He doesn't realise that he's using all these abbreviations that other people don't understand what they mean.
Most people know what an AED is.
They don't. Defibs. You'd see them in loads of pharmacies and all around. In Dublin Airport, actually, I think someone was saved on a defib, I heard, a couple years ago.
And most clubs and shopping centres will have one.
Yeah. Okay, moving swiftly onwards.
Okay, where was I? Oh, yeah. So naloxone itself, then we moved it out that pharmacists can have it and use it in an emergency.
Okay. You have to have it in stock to do so.
Yeah, and it can be people. It's like if you want to use emergency medicines, you have to keep a stock of them in the pharmacy.
Yeah.
So our encouragement at the time was that any pharmacy who was involved with OST, opioid substitution treatment, and any pharmacy that maybe did needle exchange, that they should really have a stock of naloxone.
Okay.
Because if you use naloxone in a timely manner, it gives you time. And the important thing around naloxone in Ireland, and was always my philosophy on this, was that it wasn't a treatment intervention. It was an intervention for time for an ambulance to arrive.
Yeah.
So it allowed people. So what naloxone does is essentially it bounces off the opiate off the receptor, sits on the receptor and stops the drug working for a temporary period. That's the real important thing with naloxone. It's temporary, 20 to 90 minutes. But it gives time to allow people, if they've taken an opioid, to come back and start breathing. So it allows them to come back.
Okay, and then they have to get into hospital then?
Sometimes, depending on... I think the most recent piece done by the HSE on it was that about 50% of people will go in the ambulance.
Okay.
But the most important thing is to call an ambulance, because a decision can be reached.
Yeah.
With the patient and with maybe a service. So, for example, a homeless service, they might say, "Oh well, she won't go in the ambulance." But what they'll do is they'll step up their observations on the person to every 20 minutes to make sure that they don't relapse into an overdose, because that's the risk. So naloxone wears off, and then the opiates are still in your system. Will go back and reattach the receptors.
Yeah. Oh my God, I love all this. Like, this is what I loved about pharmaceutical chemistry in college. I want to talk to you about two things, and I just want to make sure that I don't forget. So I'm going to say it now. I want to talk to you about multi-drug use, and then I want to talk to you about the socio-economic effects of drug use. As in, is it that poor people use heroin, richer people use cocaine? You know, what is your view on that from working in the services? And, you know, it's also, I think it's changed over the years as well.
Yeah, so definitely what you're seeing is, like I have a slide when I do presentation to organisations on drugs. I have it split into traditional and non-traditional. So traditional, like the most interesting phenomena in Ireland, I think, was the head shop phenomena.
Oh, yeah.
I found that fascinating from a cultural perspective.
Okay, give us a little bit of history about that.
So head shops opened up, as you know, and they were selling products that could be used, but they weren't selling drugs. There were products being sold, but if you read some of them, so there were some interesting ones like bath bombs. And one of them was labelled, if I remember correctly, it said, when using this, do not drive or operate heavy machinery. But this is a bath bomb. Why would you have heavy machinery in your bath? So what it was saying to people, there was a harm reduction message in that if you decide to use this, just don't drive. It will cause you to be drowsy and groggy.
And how would they use it? Would they snort it?
Yeah, it was, some of them, like one of them was methadone. So some people, you could technically snort it, but a lot of people would inject it.
Okay.
And again, it gave you a huge high. And what we saw actually in 2015, they brought in the Criminal Justice Act, which closed down the head shops essentially, and the whole kind of queuing for them at night and stuff for these products.
How are these things allowed in the first instance? I just don't understand.
Because they weren't being sold as drugs, and a lot of the products on the markets, what we had at the time was legislation finding out about it and then banning it. Okay. So we were banning substances, but what the Criminal Justice Act, if I'm correct, that 2015 Act, it kind of banned a whole, it was much wider ranging, and it got rid of a whole huge amount of products on the market. Like I remember when piperazine, which is a very old anti-helminthic drug. Oh, to help me
that
here,
is
Laura.
Anti-helminthic,
I know,
yeah.
but what does
worming?
That? Thank you.
It deworms you.
Drug that people were taking that was a precursor for making certain kind of products that made you high. And I remember when that was banned, I was on a really good website at the time, and it still is, called Drugs Forum. And within the instance of it being banned, there was somebody online giving the entire chemistry of the pyroflavonones, which weren't illegal, and he did the comparison to show why they wouldn't be illegal under Irish law, and they came onto the market
Overnight.
instantly. And there was one called NRG, which it kind of says what it does in the tin.
Yeah.
So a lot of these products were, from a marketing perspective, if you're interested, were amazingly marketed for not for the intended purpose, but for another intention, which
And
was
a
for
lot of
using.
teenagers got caught up in the abuse of
Oh, a
them.
huge amount of people
Yeah.
got, but a huge amount of people thought it was okay because they were legal.
That's crazy.
Because it was seen as legal. So it's a bit like, alcohol was legal, so it's okay to take these because they're legal. But the biggest issue around them was that we weren't really sure what exactly they'd do to you.
Okay.
Like some of the pyroflavones, some of them were pool cleaners, used in
Yeah.
pool cleaning.
There was a carpet cleaner as well.
Yeah. So there were all these substances that can move across. Now, interestingly, in recent times with chemsex, we've seen very interesting drugs come through, and that one of them being gamma butyrate lactate. G, which is legal because it's a chemical used for cleaning alloys in your car, for example, or cleaning computer motherboards and stuff in the computer industry. But if you decant it down to small doses and pass it on, then it becomes illegal. But G is a highly potent drug.
You just need 1 or 2 drops, and
and also it's highly addictive to keep into that kind of, the withdrawal from it is quite significant. So people try and keep topping up with it all the time.
Can you tell me what G does to people?
It's intoxicant. It's very like taking massive amounts of alcohol with micro dosing. So it's kind of like that kind of feeling, and then you top it in with other drugs. So another drug of choice is ketamine in that kind of group.
But it makes you very randy, doesn't it?
It makes
you can go all weekend.
Yeah, but then you use other substances to help you with that as well. But equally, it disinhibits you, and therefore you could have yourself in a position where you don't want to be with regards sexual encounters, etc., because you're so disinhibited and you're kind of in that moment. And with all the other substances that are used in that kind of field with ketamine, etc., that it kind of
My friend Kevin was on. He was talking about it too, and it's used a lot in the gay party scene.
Oh yeah.
And it can be very dangerous, very dangerous for people to use.
Because the detox from it is very complex. It's a very complex drug for a very simple chemical compound, if that makes sense.
And can you become dependent on it?
Yeah.
Okay.
Yeah.
So it isn't just like gives you a quick high and you enjoy it. You can actually become dependent on it too. Okay.
Because you like that quick high. Remember, that's what you're chasing, that quick high. So it's a bit like, you asked earlier, what is the drugs of choice? So I would say the drug of choice depends on the state of the nation, if I'm honest with you. So when we had our first big boom,
it was cocaine.
And everyone was using it.
Yeah.
Our most recent boom, cocaine, was again rising through the ranks. Like, there's some very interesting data from the HYPE data, which shows the admissions into hospitals. And the amount of cocaine admissions went up something like 500% over the past couple of years.
And are these admissions due to heart-related complications or psychiatric?
Difficult to find that out, but they're admissions, and coke is found in the admission.
Okay.
But it was rising massively. During COVID lockdown, street tablets were a massive problem. So unusual benzodiazepines. So we're seeing our products that were claiming to be, like, the big one was Xanax sticks, but they didn't necessarily have Xanax in them. There were also other pills being seen that, like itazolam, which is a very unusual, it's a benzodiazepine that's not marketed, but it has a different potency level to other benzodiazepines.
Benzodiazepines being things like diazepam, Valium, all of those drugs.
So a lot of those unusual kind of products were coming through the market, again because people were going to the dark web buying them because they couldn't get out because you were in lockdown. So it was very interesting the way that the drug scene modified at that time. But what I find is that there's no such thing, depending on where you come from, which is your drug of choice.
Okay.
Although
we would see more heroin addiction in lower socioeconomic groups.
But then you might see more prescription opiate misuse in your blue collar worker and higher, and your higher socioeconomic.
Okay.
But equally, what is unusual is that some recent they're not studies, from some recent reports which suggest that chasing the dragon is back, which is people who've used a lot of stimulants needing to come down quickly will take a chase of heroin.
Okay.
So, and that's how a lot of our younger population, with the ecstasy culture of the late 90s, became addicted to heroin, was chasing the dragon after their ecstasy binges.
Okay.
And then you must remember that the potency of tablets have increased. So the potency of ecstasy from our clubbing days in the has increased like 5, 6, 7-fold.
Well, actually, Electric Picnic last year, there was...
The purple skulls.
Yeah, it was 4 or 5 times the potency. And actually, I put out a little post saying, listen, if you're going to be taking this, only take a quarter of the tablet. And sure, my post was like removed from Instagram because I was promoting drug use, but in actual fact it was harm reduction.
Yeah.
So it is interesting how, you know, trying to get messages out there as well to people, it can be difficult.
But like, to give credit to the HSE and the guards, and that was that testing at that festival was a real novel move.
Now that's the testing of the drug, isn't that
Yes.
right? Okay.
So they were dependent on people going forward with the product to get it tested to see what was in it. And Electric Picnic did put up those messages on their screens to say, just so people know, this tablet is doing the rounds, be very careful, it's highly potent. There was also a couple of other substances that were unusual found there, like, I'm going to get this wrong, it was, I think, one of the 2CBs, which again is another stimulant drug. Okay. So they warned on that as well. So what I guess if you look at the way we've been moving in drug policy in Ireland, we started off with, you know, opioid substitution treatment, methadone only. Now, and then we brought in buprenorphine. Mm-hmm. We had needle exchanges. Which are they needle exchanges? You could argue they're actually just needle and syringe programs. We don't necessarily expect people to bring back their used works, but when they do bring them back, we record that they're bringing them back to prevent against drug-related litter, because that's the last thing you want with any needle exchange program is drug-related litter. Then we moved on to the overdose prevention. The testing is now another part to make sure you're safe using the substances that you've decided you want to use.
Is this testing nationwide, or is it only at these big festivals?
It only happened in recent time. That was the first time it was allowed at a festival, was at Electric Picnic last year. I am sure that the move forward is that there needs to be some sort of legislative piece around this, because technically if you have a substance, like if you look at the Misuse of Drugs Acts, you're carrying a substance that's illegal, so technically should be arrested.
Yeah.
So there has to be, I'm not going to use the word amnesty because that might upset people, but there's a certain amount of allowing the people who are there to know that somebody's going to be using something, but they're allowed to bring it in to make sure that
it's safe.
It's safe for them to use.
And you would be of the frame of mind that, you know, you would rather happen.
Oh, yeah.
And you don't think that these types of programs is encouraging drug use, because they're going to do it anyway.
Yeah, the thing here is that, you know, there's a whole piece around, you know, people talk about, we need to ensure that drugs are, you know, made legal. Whereas I would be of the opinion that, there's certain substances that we could look at for legal purposes, but equally we should allow maybe it to be the person themselves who wants to use drugs, that if they want to use drugs, they're entitled to use drugs. Yeah. Okay. So it's the legalisation of the drug user rather than of the drug itself.
And then your thoughts then on, so we get to the point where we're not encouraging people to use drugs, but we're saying this is the way to use them safely. But then you would have the argument that, so we're allowing people to use drugs, so then where are the services after that if they overdose, or the psychiatric implications of them using them?
And that's essentially what you need. You need to have those other services to wrap around that. Mm-hmm. So like to have a complete wraparound service around the individual and what they want to use or not use. And we also need to think that, you know, there's a lot of people out there who've used substances and never became addicted to them because they used them recreationally. And and people go, I used, like I had a patient at one stage who said to me, I'm not a drug user, and they liked steroids a lot. And when you looked at them, they looked absolutely amazing, to give them credit. Like they had the body that a lot of men want. Okay. They didn't drink. But when you asked other things, they use a lot of coke. Okay. And when you talked about their drug use around their steroid use, they use a lot of drugs, which is all classic signs under the diagnostic manuals, which you use for determining substance use disorder. They fitted into it. So they used a multiplicity of drugs. To get the image that they wanted, they kept using more. They couldn't stop when they tried to stop. Yeah. So they fitted into that, and when you tried to explain that, it was very hard. And the whole thing around harm reduction with that particular population was his cocaine use was all part of also his fat burning piece. Stimulants are really good at. They call them fat burners. There's a particular one called ECA, which is ephedrine, which is, as you know, is Sudafed. Essentially, it's pseudoephedrine, but ephedrine is on its own is a really powerful stimulant. So cocaine often can be replaced with that because ephedrine isn't so popular here. Ephedrine, caffeine, and aspirin is a fat burner that would be used classically by a lot of steroid users. And also, what you found was that when they were using steroids, they were using like Lasix to get rid of water, so the skin tightens more against the muscle tone, so it's better for an image.
And would they be doing this all the time, or was it only in a build-up to
So
competition?
sometimes they call it cycles, and you upcycle and you downcycle. But my experience was that they would downcycle but never come off it, because the biggest problem with using steroids is that it stops the natural testosterone from being released in men, so the testes shrink, where your brain talks to your testes to release the hormone. It stopped because so much is coming from the outside. Your body doesn't need to produce it anymore. And if you stop it suddenly, it causes huge amounts of problems for steroid users, because
Like what?
they're not able to produce testosterone anymore.
Okay.
So they have to restart their testosterone use. So often they use hormones that are classically used. So Pregnal, for example, they'd use in order to stimulate the axis to start working again.
So Pregnal is actually a drug that's used in IVF.
Correct. Yeah. So and also they'd use drugs like Arimidex, as you know, which is used as for hormone post breast cancer. They'd use that to stop forming bitch tits, as they're called, because they need to get rid of the estrogen, so the estrogen doesn't create the breasts. And the big thing with gynecomastia, which is breast formation, is that it's irreversible.
Okay.
So if you had used it and you got big boobies, as a man, you'd have to have them operated on in order to get rid of the excess tissue.
And the gynecomastia, or the breast bitch tits, as you say, is caused by the steroid use.
Yeah, because what happens if you use excess testosterone, it's converted to estrogen, and estrogen lays down like that.
Okay.
So that's why they'd use the Arimidex to stop the estrogen from stepping down, from forming. So they're a very complex group, a very interesting group, highly intelligent in their use of drugs, and highly knowledgeable.
I'm just thinking,
in the products.
They know an awful lot.
They know a lot about which products work best, and there's certain ones that are better in female than in male. They also there's a huge amount of them that come through the black market process. And I think, I don't know, did the HPRA have something recently about the millions of products of these particular products that were seized last year? So there's a huge market for them.
Do they get erectile dysfunction as well?
Completely.
Okay.
Because
their
your
willies shrink as well?
Yeah.
Okay.
So a lot of them will take a lot amount of ED drugs, such as
erectile dysfunction drugs, guys. He's using abbreviations again.
Erectile dysfunction drugs such as sildenafil, Viagra, Cialis. So they'll use all of them as well.
Okay.
So,
and is there an awful lot of them? Is it a big cohort of people?
I would say it's bigger than we know.
Okay.
Because this cohort don't come forward for treatment class. They know, they're highly knowledgeable in their drug use, and they don't see themselves as drug users.
Okay. And they don't necessarily have the problems that they would perceive.
Yeah, like I'm thinking of the guy that I remember looking after, and he was on erythropoietin, which is increasing your red blood cells, so you exercise more. Some of you may remember lovely Lance Armstrong loved it. It gave him more red blood cells, so more oxygenation of the blood. Equally, if you're a bodybuilder, it gives you more power to lift heavier weights. That's what steroids ultimately do. They don't make you turn into that amazing body. You have to do a lot of work to get that amazing body, but it allows you to push yourself. But this guy, he looked amazing. His skin was amazing. He was also taking growth hormone, which is, again, to help with bodybuilding. But the only thing that we managed to get an intervention around him was that he kept saying to us, I'm fine, I know what I'm doing. But he had a lot of sensitivity on his nipple area, and that's one of the classic signs of the starting of gynecomastia. So what we did do, at least the intervention we did with him, was a reduction of some of the the testosterone-like drugs he was taking to bring it down to much more, to pare it back a little bit rather than using all of them because that was creating too much estrogen in his body.
Okay.
So he brought it back. But again, there's very interesting studies from Liverpool, John Moores University, around the cohort, and the HIV is a problem, is being seen as a problem in certain steroid cohorts.
Okay.
Because they share.
Why do they share?
Because it's not seen as sharing. They're not sharing needles. They might be sharing the vial of steroid and they're dipping in and out.
Oh my goodness.
So, and they don't see that as like possible transmission point.
Okay.
So, and hepatitis C is the other one.
That would be huge, yeah.
So so this cohort may eventually come out of the woodwork, that we'll see more people.
And how did it come about that you were seeing these people?
We went to Tim Bingham and myself at the time had a really good contact in Scotland, and he ran a specific steroid clinic, and we had concerns over steroid users here in this country, that Tim is really good at kind of finding people to talk to about issues, and he was saying we were seeing a little more steroid users. We were talking to people in needle exchanges, and then people come in for really unusual needle types. They weren't coming forward to our classic needle exchange programs because they saw those, as you said earlier, for people other than them, because we're not drug users. And then we looked at setting up people on the street who were working with people, saying there's loads of these people coming forward about steroids and asking about our needles. We know nothing. So we started developing a training program around that. And then a specific needle exchange opened up for this cohort.
Okay.
And it is a different cohort.
Okay.
So you have to modify your services sometimes to suit your cohort.
Well, that makes sense.
Yeah, but at the time it was really hard to say, what is it? We don't know what it is yet.
Okay.
But like for me, where I saw a lot of people were who were coming forward for other addiction issues, not only just steroid, but the guy I'm thinking of in particular was attending for a different addiction at the time. And we just noted that he'd bulked up hugely over a period of time and was looking, you kind of go, oh, you're looking really well, you're working on the gym. Yeah, I am. And then through him, we came across a further cohort of 17 to 18 year olds who were doing this dipping from one product.
Okay.
And then from them that we found more that were in that cohort, but kind of dabbling, not using all the time. But equally, there was this kind of message out there that use steroids and you get a body like this. You need to use steroids and work like a devil to get the body like that.
Okay.
Like it doesn't automatically create it. So there's a lot of work that goes into it. And they're very disciplined. And when they get the right kind of balance for themselves, they are very knowledgeable in their drug use. Yeah.
And all of these drugs from the black market as well. So
black market,
dangerous.
yeah. Well, they're not HPRA endorsed. You know, they're not a medicine on the market per se. They haven't gone through any quality control measures. Like there's some very interesting pieces online around it. Like I know that a lot of people would go to Thailand and Turkey for them, and often you'd find hairs floating around in the vial, and
oh goodness me,
you don't know exactly what's in the vial, or you'll see 10 vials in a row. They'll all have different volumes and different colours, but yet be in the same pack.
Okay.
So like there's a lot of there are a lot of counterfeit meds. It's very hard to say, but then of course there are prescription ones out there as well.
Okay. What's the different type of needles that they look for?
They look for heavier bore needles, obviously, to draw out a bit, to draw out, and then the change in needle for a deep IM, and equally intramuscular. Sorry, and what you're doing with steroid use is that you have to be very particular on the volume you put in, because otherwise you cause damage to yourself. I remember going online looking at this guy, and he was telling people how to inject properly. He was kept injecting the top of his thigh, which is not a great place to inject. And he kept saying it doesn't cause pain, but his face told a different story.
Okay.
So it's always if you decide to go into your arm, you need a big arm to inject the volume, because remember, it's like a depot injection.
Yeah.
So you need a big arm to inject to inject into your arm.
A depot injection, by the way, is an injection that goes in and it almost forms a reservoir, and it dissipates over time in the body. It doesn't just go into the body immediately.
So we would recommend outer quadrant of your buttocks.
Okay.
Nice, heavy. You can put in about 2 mils into that. So, and they like bigger barrels or bigger syringes.
Yeah.
So they're slightly different.
There are issues with polydrug use. So someone isn't necessarily...
So I as I say to everyone, I've never come across the unicorn as a uni-drug user, because I've never come across someone who just misuses a singular substance. There's always a combination.
Okay. So how difficult then is it to get them off everything?
Extremely difficult.
Okay.
So for me, when I was involved with the addiction services, I was the pharmacist on site in one particular location. We would always challenge those who said to you, like, it has to come from the person themselves if they want to come off something. Mm-hmm. Me telling them to come off something will never work. It has to be them themselves. No family saying I want them off. You know, they have to make that conscious decision. So we would always tackle the benzos and Z drugs first, because they're really challenging.
And benzos are benzodiazepines such as Valium and diazepam, and Z drugs will be your Zimavanes, your Zopiclons, your Zolpidem, your sedatives, basically your sleeping tablets. Yeah. That can be short acting or longer acting, but they're, people can become very dependent on them, and they use them in a different way. So can you explain the use of those drugs, please? Not in the contemporary sense, in the drug abusing sense.
So
how do people use Z drugs and benzos?
Oh, lots.
But what do they get out of them when they're taking?
You get zoned out of it.
Yeah.
So it causes you to relax. It's a bit like at one stage we were seeing a misuse of they were called lilies, which was good olanzapine, which is an atypical antipsychotic, because again it causes you to, if you take enough of it, you just zone out of it.
Yeah.
You go into a deep stupor. So it's a bit like using heroin. Pregabalin is another one that's being used extensively to cause that.
I want to talk to you about that later on.
So benzodiazepines and the Z drugs are...
You try to get them off them first.
Yeah, because they're really complicated to detox from.
Why are they so difficult and complicated to detox from?
Because they're very slow and steady wins the race with them. So to detox off a benzodiazepine, you have to... And a Z drug, we classically bring them back to the parent compound, which is good old Valium, 1963 or thereabouts.
The housewife's dream.
Yes. So, and it did replace, people need to remember, it did replace a very toxic drug, which was the barbiturates.
Well, that's true. So we don't see any of them anymore.
No,
sure we don't.
No, very rarely. You see a little bit of phenobarbital maybe for in epileptic patients, certain epileptic patients. And the only other time you see it is if you have to put a dog down.
Yeah, and the barbiturates back in the 50s were dangerous because they not only are they highly addictive, but they're also, if you overdose on them, like, they're dangerous. Whereas the Valiums, the benzos,
the word we use has a very narrow therapeutic window, Laura.
Yeah, okay. Well, I'm trying. So yeah, the difference between overdose and therapeutic dose with a barbiturate is small, whereas with Valium, it's very difficult to overdose.
So it's really on their own. It's really difficult to overdose on a benzodiazepine. You can do it, obviously, but you can take quite a lot of them without causing harm to yourself. The problem is that people always combine them with alcohol, heroin, and once you start combining drugs like that, what you're now doing is they're all working together to do the same thing. So they reduce your breathing, reduce your responsiveness. You could aspirate vomit and drown your own vomit. So hence they're really dangerous in an overdose situation. But the detox of a benzodiazepine, we bring it back to Valium, and we would never in the services really go above 30 to 40 milligrams a day.
Okay.
Even though people could be taking 200-300 milligrams a day. So we get people themselves to almost come down. The biggest challenge then is that if you're doing a benzodiazepine detox, you actually don't know if they're topping up. So there's a huge trust piece between you and the patient.
Okay.
Because I have no way of deciphering if you're taking benzodiazepines outside of me having them within the service or from a prescription versus you getting them on the street, because the same compounds will show up when you do a drug test on it.
But sure, isn't that the same with methadone or anything like that?
No, methadone, see, it's metabolite. Methadone, it comes up as a metabolite. Once it's taken, you can test for the metabolite. So, and you can test that it's heroin. But people can top up with extra methadone, but it's unusual. And why they're topping up with extra methadone is you'd have to argue, are they on the correct therapeutic dose?
Okay.
Whereas with benzos, it's really hard. If I'm giving you Valium, you can go out and get more Valium, top in, and I can't say you've taken excess other than maybe observing you when you come in for your prescription or something in the pharmacy, or going in to see your doctor that they notice something different.
Okay.
So you do a very slow detoxification, no more than 2 to 2.5 milligrams every 2 weeks.
Isn't that so small?
Patient driven. So if Laura, the way I used to run it was very simple. So I would say, we're putting you on this, let's see how you get on. So 2 weeks in, I would say, so are you ready to detox? Come down a little bit. No. Okay. So another 2 weeks. So it was always patient driven.
So that's 2.5 mgs a week. You're saying that
a fortnight.
A fortnight. So I've seen, though, prescriptions being written for people to detox off Anzicam by doctors, and they are very quick. Way too quick.
They won't work. People won't adhere to it.
No.
The thing with it is that the patient has to be behind it to drive it. Okay. They have to be fully involved that I do want to come down off them or reduce them. Like the way I looked at it is that the Nancy Reagan area of kids stop using drugs doesn't work.
No.
So it's like even when you're dealing with someone who has a nicotine addiction when you're in the pharmacy, you always say to people, I always say to people, just bring down how many you're using.
Yeah.
So come down from, if you're smoking 40 a day, sure, if you can even bring it down to 35 next week.
Yeah.
Or the week after, that'd be great. So you're not saying stop, because the minute you say stop to people, there's a resistance put in the place. I can't do it, which is true. You can't do it.
Yeah.
So you have to encourage people to reduce the use. So to bring it down slowly. You might never get your smoker off everything. They might still use 1 cigarette a day, but to me, 1 versus 40 is surely better. You know, if you're looking at it as a harm reduction. And there's some really interesting studies around smokers and heroin users and the similarities between them.
Well, they say that smoking is as addictive.
It's a very complicated drug to come off of.
Yeah.
And, we all, in college, you may remember the gateway drug being thrown at us all the time. Let's wonder if the gateway drug is nicotine and alcohol, Maybe they are the gateway drugs. Instead of cannabis,
okay.
which was always thrown under the bus as the gateway drug to everything else under the sun.
I have my own thoughts on cannabis, and I'm interested to hear yours.
On cannabis?
Well, hang on, let's finish the detox.
Detox. So it's 2 to 2.5 milligrams every fortnight or longer, and even lower. You might decide 1 milligram a week.
Okay.
But you try and bring him down as slowly as possible because of the risk, if you withdraw too quickly, of the risk of having a seizure. That's the real dangers of benzodiazepine. They're called benzodiazepine fits, a benzo fit. So you bring him down really slowly. So once you have that gotten rid of, so let's say you now have gotten rid of the benzos and Z drugs.
Jesus, that's a feat in and of itself.
Yeah, so they're on their methadone or buprenorphine to treat their opioid addiction. They're doing really well on that because they're not topping up with anything else. And sometimes you actually have to have a trust with your patient that it's like you're not using, you can look at my urine. I don't need to look at someone's urine to know if they're using or not.
Okay.
I would ask you, have you used today?
Yeah.
And if they go, no, I have to take that as no.
Okay.
Or I might say to someone, did you use something today? You look a bit off.
Yeah.
Was my usual phrase. And sometimes they go, I might have used something last night, Dennis. That's all right. I'm not, that's fine.
You're not the police.
Correct. And the whole thing with urine screening and all of that was that, what were you really going to do with all that information anyway? You weren't going to, it wasn't going to do anything more than maybe if you felt a bit unsure about where they wanted to go with their treatment, you might use it now and again, but it wasn't something you'd use all the time.
Okay.
So you try the benzos because they're so complicated to come off of. Cannabis. When I joined the addiction service first, we saw cannabis and was like, let's leave it alone. It was just too...
It's a pain in the arse, isn't it?
It was just a really complicated drug to deal with, and trying to get people to look at their cannabis use. We tended to, I would say, ignore it. It probably needs more attention, if I'm honest, particularly around its use and potency. Because remember, again, Laura, I'm bringing us back to the heady days of college. Cannabis in the heady days of our era, my era, was marijuana, leaf grass
Yeah.
was probably 0.5% tetrahydrocannabinol, the stuff that makes you get stoned.
Yeah.
So very low concentration.
Yeah.
Whereas fantastically, we've moved forward in modern era of hydroponics and cell culture and plant cell culture, where now we can
basically
have
have really clever people making really good shit.
correct. So they've increased the concentration of THC enormously.
Yeah, it's massive, isn't it?
Yeah. So you're talking about it can be potency levels, up to 15-20%.
Mm-hmm.
So that's a huge jump.
And you just don't know what you're getting, which is the issue, isn't it?
No,
right?
and some people like there's a huge issue out there with things like skunk and pollen, because of the high strength products that are out there. And then we don't know, are they lacing them with the cannabinoids, which are synthetic cannabis products? Like you know about the edibles.
Mm-hmm.
Like what is in those edibles? Is it THC or is it cannabinoid? THC, we have some idea how it works. Some of the cannabinoids, no idea.
Yeah.
Like they're your Fubanax and all of these wonderful words. Like if you look at the chemical nomenclature of them, they're like this length,
I know,
they're
massive.
enormous names. So one of them I know was Fubanac at one stage, was a big problem one. And we don't know really what they do. We saw them kind of in the early thousands, where people were being admitted to hospital with eviscerating themselves with huge psychiatric kind of drug-induced psychosis.
Yeah.
And the whole idea there was that what we saw were these people had taken this drug that's really like, I'm going to use high strength THC, but it's not it's a THC type.
Derivative.
Yeah. With nothing, like there was no CBD in the drug. And that's where people always felt, maybe CBD has this neuroprotectant factor. So it would stop you having this, severe damage to...
So CBD just is the
Cannabidiol.
non-THC part of the cannabis plant. So it's the thing that can be sold in health food stores and pharmacies so long as it has no THC in it.
So long as it has no THC in it.
None, not even a 0.00000.
Zero. It's a definite
Put it
zero.
this way, Fabu isn't going to come out with this CBD anytime soon. Anyway, it's too much of a pain in the ass. But I need to ask you, do you think that cannabis should be legalised and therefore we pay tax on it, it is properly regulated, there's proper percentages,
Okay,
we know what we're getting?
we know the jury's out on it, in the sense that in some jurisdictions what they're saying is, by legalising cannabis, the use of heroin has decreased and the use of other substances has decreased. And then you're seeing on the anti side saying, well, also evidence has shown by legalising it, it's increased the youth drug population. They've modified their drug use. They start using cannabis, but then they move on. Or psychiatric conditions have increased significantly. Like there was a really interesting paper done by the BMJ a number of years ago now, which talked about high strength THC products and the risk of drug-induced psychosis associated with that and mental health conditions. So we do know there's that link. So what is it that we need to do in order to legalise it? So if you think about this logically and look at how we do alcohol in this country, we do it very badly. We know there's lots of under 18s who access alcohol regularly. Mm-hmm. Okay? So if we were to look at cannabis, it's all about neural network development. We have to be mindful of that. So you're talking about 21 plus maybe that you'd legalise it from. If you were to go that route, how good would we be at policing that? How would it be policed? How would we manage it?
Yeah.
I would say badly, if I'm really honest, because we have alcohol to look at and how badly we manage that. Could it be legalised? If it was legalised, I think we'd need to be very mindful that we looked at all evidence around the world before kind of looking, because each side will look at what they want. And like I know there's a huge move forward towards having cannabis made more widely available. But I think people need to think logically is, if it's made legal, how is it going to be managed? As you said, will it be sold in cafes? Will it be sold in bars? Will it be sold through pharmacy? Would it be sold in your supermarket? Only 12 plants today in the supermarket versus you can buy 24 in the pharmacy. This kind of thing. So I'm not sure how that would work. We'd need a very robust policy on it if we were to do it. And I mean robust policy in the sense that I know people say, but look how it works really well in Colorado. But is it working really well in Colorado? And often it comes down also to how and what products we're looking at here. Yeah. Is it all going to be all products, edibles, the lot? So accessibility, we know there's been issues around edibles in the country in recent times because they contained a lot of THC along with CBD. And we have to be mindful that edibles are, now we're moving into a different marketplace. So for me, what I find really strange is that when you see certain companies who manufacture these products moving into the soft drinks market to put CBD into soft drinks. So is it all about money and the drive for money rather than people actually having accessibility to a safe product?
I think it's all about money.
Yeah, so for me, it would always be a safe product. Like, we have to make the product safe for the end user. So if you think all of what I've been talking about is harm reduction and making sure that it's safe for you to use the drugs, allowing a legalization of a product that we don't know how it's made. Now, I know that, now I could get the country wrong, Croatia, I'm going to say, the government grows their own.
Okay.
And I think in Israel, I think they might grow their own for sale to their own places, so they know what they're selling into the marketplace.
And in Amsterdam, how does it work? Or what are your thoughts on the Amsterdam model?
The Amsterdam model, like, it's interesting in Amsterdam, isn't it? You're not allowed to smoke tobacco inside, but you can smoke cannabis inside. I find that really strange. Like, the Amsterdam model, like, it hasn't demonstrated, harm to a great extent. Is it a big problem? Anyone that I have seen go there say there's a big drug culture there anyway. But is that any city in the world? Okay. To be honest with you, I'm not against nor pro at the moment until the evidence kind of comes forward a little bit more.
You're a real diplomat, aren't you?
No, but it's not that.
Run for government,
no, but my big thing around it is that legalisation of any substance needs to be given due consideration because of its ramification on other parts of legislation. Mm-hmm. So we just need to, doing cannabis, that sounds really easy, but it's not so easy because of the way it's structured within our legislation. Okay. So there's a lot of work that would need to be done from a legal perspective in order to bring that out. And that's why I think people say legalising the person who wants to use the drug is much easier. And that's why, there's, levels of you on your persons is not seen as sale and supply. So you get less. So it's not seen as criminal offences are reduced because of it. Yeah. If we were to go down the route of legalising it completely, for me, it would have to be, we'd have to have a robust kind of policy in place, public health policy, I don't like to use the word police it because that's not the right word I'm looking for, but how we'd ensure that people who want to access it can access it safely and that it's a safe product for them to use.
Yeah, okay.
So it would all be down to, like, what is your manufactured product? What is it going to look like? And what strengths are we looking at? How often can you access it? What happens then when you go down the route of somebody saying, I have a chronic problem with cannabis that I need to use it every day? And the payment and cost of that for the individual. Okay.
What are your thoughts on codeine?
As a pharmacist?
Yes.
It's a very unelegant drug for pain.
That's a lovely way of putting it.
Yeah. You remember Prof. DC?
I do.
He was talking about elegant formulation.
Yes.
To me, codeine isn't... it's kind of a dirty opioid in some ways, from a pain relieving perspective. As a CD5 in this country, controlled drug Schedule 5, pharmacists can give it, provided they ask 1,002 questions.
People know the answers to the questions.
Oh, they do, yeah.
And, pharmacists are torn, I think, between people that come in and that genuinely need it and are not abusing it because there's many of them and they find that that can help them. Or is it the codeine that's helping them and not the other drugs that's helping them? That's the question as well. Because, there is the therapeutic dose of codeine that works, and the 8 milligram that's in a lot of the OTC products isn't considered to be therapeutically working. Isn't that right?
Yeah. For me, it's the development of a problem with codeine over-the-counter products is actually the harm that will be caused by what else is contained in that product.
Yeah.
So your paracetamol damaging your liver, the ibuprofen affecting your kidneys and stomach. So it's that. Like, I had a patient that I think he was taking 200 Nurofen plus every 2 days, 2-3 days. And what brought it forward that we figured out there was a problem when he came to the service was that he was actually admitted to hospital for a blood bleed in the gut
Yeah, because of the ibuprofen.
because of the ibuprofen. Did he have an addiction to codeine? Yes, he did.
Yeah.
Like he was taking a lot of codeine in that combination. Treatment options, he was placed on an opioid substitution treatment program.
So like a methadone program.
Yeah, I think he went on buprenorphine.
Okay.
But again, buprenorphine isn't the answer drug either to codeine addiction. It depends on the person. It just suited him at the time.
Okay.
But for me, to have a prescription only, it's taking away a certain power that we have as pharmacists, that maybe we need to like sit in that power and actually be a little more like, no, you can't have it.
Be more proactive.
Yeah. I think from my perspective, it's a challenge in pharmacy all the time that you'll get abused by people when you refuse it, and you might kind of go, having a bad day, and you kind of go, just have it. I just can't deal with you today.
Yeah.
You know who's coming in and using a lot of it. Yeah, and you keep an eye on that. I know some pharmacies themselves have taken upon themselves to keep a register of who's coming in, going, so that they are monitoring it. But then my issue is that, so what do I do with Laura, who I know is taking all this Nurofen Plus? Where do I refer her to?
Yeah.
Is there services that I can refer to? Is there a counselling service locally? So if, let's say, tomorrow morning the decision was reached that, we're going to move it up in the schedule so that it now is prescription only, I think we will end up with people coming out of the woodwork that we haven't copped. Because there's some very interesting pieces out of Australia on codeine addiction when they did that in Australia, and
when they put it onto prescription only,
and how the population that nobody knew were misusing it, or whatever way you want to describe it, using it inappropriately, not by two every 6 or 8 hours. That they were. Like one woman described herself, her quote was that, I didn't know where to go with this, and now I don't know where to go, because now I have a problem that I am just like, and she used the word addict, which is a word I hate using. I'm just like an addict. I can't get my next codeine because of this. So we need to make sure that if whatever we do, that there's a pathway for treatment if people want treatment.
But there's the services are so shocking anyway.
Well, the services, I don't like the word shocking. I think we have very good addiction services.
Excuse me now. Let me rephrase that. We have good addiction services currently, but I don't think that we would have the infrastructure.
No, we wouldn't.
In place to allow for what we probably think is an underlying issue for a lot of people that would need help.
Correct.
And
I think they could be overwhelmed.
Yeah, I think they would be. And even sending people into GP, into the doctor for these this codeine, does the doctor have enough time to see these people as well? Like,
and what do you give them?
I know. You just give them prescription codeine then.
Do you give them Codant prescription codeine, or do you give them more Solpadeine that they get? And then if you came in for Solpadeine, and let's just say we all know it's maximum of 8 and 24 hours, and suddenly a script comes in, let's say for a pack of 60, and 24 hours later the person's back in for 60.
Yeah.
So conscientiously as a pharmacist, you know that have they taken all of those in the 24 hours? And if they have their liver, to give them it again, you now could actually cause them to have liver poisoning.
Mm.
So like, what is it that we need to replace that with? Or do we need to look at it as that, okay, so if you have that much of a problem, we need to look at placing you on some sort of treatment option program. So buprenorphine, methadone. Could you use codeine to treat codeine addiction? Of course you can, but then you don't know if they're topping up with codeine when you're giving codeine, because the metabolites will be the same when you're if you want to test that. But equally, you could give it.
Is it easy to reduce down from codeine themselves? So say they're using 24 a day. Could they go down to 22 a day, or 23 a day for a week, then 22?
What we found with those that have come forward for treatment is that there's other issues going on with the individuals. So sometimes there's mental health issues. Sometimes there's issues personal issues going on for them, and this is why they take it.
Okay.
And sometimes you find that there's other drugs involved, be it alcohol and maybe a little bit of some cough bottles might be liked on the side.
Okay.
So you find that it's kind of wider than you originally thought.
Yeah.
By just delving a little bit in, and like other products like over the counter that they might be taking, such as some of the sleep aids are also implicated.
Isn't it amazing the way the human brain works, though? We are pleasure-seeking animals.
Yes.
So we will eat, we'll have sex, we'll take drugs or drink alcohol. It's funny how we don't consider alcohol to be in the drug category, but it is very much.
Well, at one stage it wasn't, but it was drugs and alcohol. But it's all they're all drugs. Like,
so we're just, and I think that the way we look at it, I hate the term junkie, addict. I hate the term as well. But the potential in all of us to become dependent on a substance of such.
Well, like when you talk to people, like, and they say, "Oh, tonight, Friday, I'm going to have a large glass of wine. It helps me relax." You have a time and date in your head of when you're going to have it. So you could argue, if you didn't have it on Friday night, so you're planning it all week for that. So people, if you're using drugs, people equally have a tradition, routine around how they use their drugs.
Yeah.
So you could argue that we all like that kind of idea, that we set times and for that I'm giving myself this pleasure.
Mm-hmm.
So, yeah, can everyone become addicted? Potentially.
Mm-hmm.
But some of us seem to have wherewithal not to move into the area. Don't know why.
Yeah.
I'd love to know the answer, because then you could look at, the whole thing is that with genetic testing moving forward, will they find some sort of anomalies in people who go for the big highs, like people jumping out of airplanes,
Yeah.
Parachuting, bungee jumping, like they're all looking for that kind of adrenaline. People call it the adrenaline junkie. So,
Yeah.
when you take, for example, cocaine, it causes every positive neurotransmitter in your brain to be released. So your adrenaline, your noradrenaline, it affects your dopamine receptors in your brain, which are all your pleasure-seeking receptors. So, like, again, people are looking for that whole kind of pleasurable piece. When people take heroin, there's a pleasure to that by being zoned out of it, even though some of us are kind of going, oh no, I prefer to be more active. But that some people like that feeling of like going in on themselves and kind of calming down and relaxing themselves downwards, versus somebody taking like a stimulant. Like, think about all the rave culture, or how much, like, ecstasy again was highly used, and people, it was all about the release of endorphins, the release of positive neurotransmitters, to be the empatagons, so you're all loved up on them, so it was like a whole, like, so yeah, it's all pleasure seeking no matter what way we look at it.
Pregabalin is the drug of the day at the minute. The Lyrica.
Gabapentinoids, yes.
Yes. So there's a lot of it on the street. It can be bought, so it can be sold so cheaply on prescription. And I had an issue with people that were coming into me as well, that were getting a lot of pregabalin with back pain, and they were definitely selling it on the street. But that is an issue. So when it was, I suppose, when it bottomed out price wise, it was able to be sold on the street for, I think it's 30 cents in the dispensary. People might be able to buy it for, and they can sell it on the street for €1. This is a 100 milligram tablet. Mm-hmm. So it's another drug that's causing serious issues. And actually, I was speaking to a Garda there recently, and they said that they are actually, the drug hauls that they're doing, there's huge amounts of pregabalin being taken and seized.
So if we look at our overdose stats in this country, so the National Drug-Related Death Index, the last data we have is 2017. I won't go into the ins and outs of why it's only 2017 and not sooner. That's another day's conversation.
Here all day.
But pregabalin being implicated as a drug in overdoses is increasing. So, like, it's in double-digit figures that it's been seen. Pregabalin itself, interesting drug. When it came on the market, like, everyone thought it was, like, it has a fabulous wide range of indications, let's be honest. It's used for generalized anxiety disorder. It can be used in epilepsy, used for neuropathic pain, you know,
It is an amazing drug.
yeah, so it has this wide range. So how does it work? So we all know that it is not a benzodiazepine, but yet it will affect the same receptor as a benzodiazepine. So it affects the GABA receptor, which to me, I like to describe it, the GABA receptor is this donut that sits on your nerve. So your nerve is like going through the center of the donut. So when that's not affected, the receptors allows the rope to allow messages to go through. Once you get the lyrica affecting the cascade and it comes down and hits the GABA receptor inflates and stops neurotransmissions. Hence, it helps with pain in nerve endings, helps with anxiety disorders because it calms people down. So it does all of that. What I found most interesting with the drug was the way that you had to be dose inducted and dose reduced after it, which always to me implied that there's a problem with this in some way, that there's an addiction issue around it.
Goodness, aren't you the clever clogs?
So, and also there was interesting data coming out of the States, was it around 2000, 2001, around potential addiction issues associated with pregabalin.
That long ago? Okay.
So from my perspective, it has a therapeutic use. It's like benzodiazepines, but people go, oh, we should just get rid of them. Benzodiazepines have a therapeutic use. Everything has a therapeutic use. It's just when people now suddenly discover that they also have a way of using them in a different way to get a different buzz off them.
Making you...
But our big problem is that the amounts then that people are taking, like I think I saw on Twitter recently, it shows my age that I'm on a Twitter, about calling them coffin pills because of deaths associated with them.
Yeah.
And again, how they work is they slow you down. So that's how they work. Slow you down and cause you to go into a deep stupor, may reduce your breathing, your hand-to-eye coordination, your reflexes. You may aspirate, vomit and die because of it. But invariably, it's always, there's other drugs implicated in with it. So purely on their own, the dosing of those is quite high.
Yeah.
And we've seen people on quite high doses and they don't really have... And, they might get a bit groggy, but they develop tolerances around that. But the more and more you take, the more inherently you're heading towards the risk of an accidental overdose associated with them. But gabapentinoids, in my opinion, probably should be controlled drugs.
Yeah.
They've done it in the UK.
Say they find it very difficult to come off them when they're
really
on them.
complicated.
Yeah.
But you've had patients who will come down off them quite slowly, and even at that, it's so I kind of and I know that the companies who make them will give out to me for this, but I treat them a bit like a benzodiazepine. So you need to do it very slowly and steadily to bring people down.
But I think even things like antidepressants like escitalopram, it should be really slow and steady. And I see people being reduced off them over a course of 2 weeks, and I'm like, really, you need to be. Really
Well, you're always worried about the serotonergic surge with those, which will exacerbate the problems to make it even worse. Yeah, no, I think with anything like that, the slower...
Anything that's working on the brain like that, the slower you come off, the more... You just give yourself more of a chance.
Well, equally, you allow things to equilibrate, I think.
Yeah.
And, like, there's a lot of... do we know enough about them sometimes? I don't know if we do. You know what I mean? We know exactly how they work and we know it affects this and that, but do we actually know what happens when, what exactly happens at the end of that synapse? What exactly is going on there? Do we know, do we know enough? I've always believed that anything that can alter the brain, as you just said there, has the potential for us to use it in a different way to get a different buzz off the drug.
Yeah.
So who would have thought that an atypical antipsychotic like olanzapine could be misused?
I know.
Like as pharmacists, we kind of go, nah, that's great, can't be misused. But then we should have known because we knew that thyroidazine and Largactil were highly misused as well. Amitriptylines were highly misused, tricyclic antidepressants, so why are we're always like, oh my God, I can't believe that. When really there's loads of history behind us telling us that these are all potentially can be used in a different way. I don't like using the word misused at all in case... I like to use that can be used differently.
Okay.
That people can go off piste with their therapeutic use of them. So look at all the compounds that are out there, that are nootropics, for example. They make you work, keep you awake. All the potential use off label for those by people when they want to access them. So there's a lot of products out there that have the potential of being used not as how therapeutically indicated, but people know that if I use it this way, I'll get a different hit from it. And like, to give credit to people who use drugs, they're very clever in how they combine their products.
Oh,
They
yeah.
kind of have an idea of exactly, so if I take this and this, so a classic one is the speedball, which is heroin and cocaine mixed. Like, that is a wonderful combination of compounds, in the sense that taking in cocaine by injection is extremely rapid. Like, the hit is extremely rapid. So it goes into the brain very quickly, causes all the synaptic release of positive neurotransmitters. And having heroin mixed in with it, the heroin is much slower. And as your high is hitting, your heroin will be coming in, so you won't have a difficult crash associated with it. So it's kind of using the effects of one to mitigate against the bad effects of another. So you come down softly. It's a bit like chasing the dragon after a stimulant use, taking heroin after that. It brings you down nicely rather than crashing hard.
Yeah, it's just clever use of them, isn't
Yeah.
it?
And we have to acknowledge that
100%.
amongst people who use drugs, and that's for all cohorts, like your more hard to reach populations like chemsex, steroid users, tanning injectors. They know what they want the drug for. So we're just there to ensure that if they're planning on using it, that it's done safely without, and if there's harms being caused by the drug, that you can warn them about those harms.
Yeah. Can I just ask you a little bit about the services that around the drug use services? So apart from the needle exchange and apart from the merchant's key and people that can go in and access treatment there, what about the psychiatric services? How do they stack up for people? How do the rehabilitation services stack up? If someone's going to detox, like what you said, they might detox beautifully and have a great time in there, or it'll be difficult, but they feel hopeful coming out, and then they're back into their old life. How easy is it for someone to come off and stay off? Or
I don't think it's ever easy,
Okay.
to be honest with you. I think, I can think of and this is, you can either argue good or bad. I can only think of a few people that I am aware of that came off during my time in the addiction services. But I equally can think of a lot of people who did really well and moved on with their lives. So
yeah,
the argument there is that, like, sometimes people say to me, you're keeping people on this stuff for life, blah, 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 blah. But equally then I will argue, so if we stop it, is it like telling somebody who is a type 2 diabetic who needs to lose weight that we'll just stop giving you drugs unless you lose weight?
yeah,
So we need to be mindful, what are we doing here?
okay,
So for me, somebody on a methadone program who gets back in with their family, maybe accesses their children, has a really positive relationship, holds down a job, integrates back into society, whatever way you want to describe that. I hate using the word normalizes.
yeah,
That's surely a positive thing.
absolutely,
Somebody who comes off it completely, that's an extremely positive thing. Very challenging, I think, for all of us, and the psychosocial side of offering those services is through a lot of our voluntary projects that exist out there, that are funded by various funding agencies like Section 39 from the HSCs, that they offer that kind of support service for families, for the person themselves, that they can access maybe counselling services, because a lot of this is like triggers. We need to be mindful of what their triggers are. So there was a very interesting study done by Professor Bell. It was called Smoke, and it was about nicotine smokers, that you'll have a cohort of people who smoke who will never give up. Okay?
yeah,
So you'll have a cohort who will go on to nicotine replacement therapy, will never come off nicotine replacement therapy. I know I have patients in the pharmacy where I work. They're always in for their nicotine replacement therapy. They don't smoke anymore, but they're
No.
on nicotine replacement therapy. Then I have one or two that I know that have detoxed off their nicotine replacement therapy, for want of a better description of it, don't smoke, and are, I'm going to use the word drug-free, nicotine-free,
okay,
living their true authentic life. But then I had one who was happily on holidays in Spain, got a whiff of a cigarette and relapsed.
okay, yeah,
So what we need is if somebody relapses after a detox, after doing really well, we need to have rapid accessibility back into service. And I think to give credit to the addiction services and other organisations, that has improved immensely over the years.
Okay.
Like during COVID, induction into treatment was extremely rapid.
Why during COVID?
Just because it was just people wouldn't be able to access their drugs as easily, and increased accessibility was really important to get people into treatment. So they increased accessibility, so we know the capacity is there to do it. So in some ways, with codeine, for example, back to codeine, maybe there is capacity there to do it, but I think there'll have to be more capacity building done, and equally we are going to have to look at, and how the National Counselling Service would link into that's offered through GP surgeries around the country, how they if I'm down in Ballygo Nowhere and there's a counsellor who comes into the GP surgery, will they see me now? Can I go to that surgery for my counselling treatment, because that's the only counsellor for miles around? I can't afford to pay for counselling, but I have a codeine addiction and I need to, talk to someone about it.
Okay.
So we just need to probably integrate with other primary care services. Addiction services need to do more integration, but equally primary care needs to do more bringing in that piece into primary care, which I think is ongoing all the time.
Yeah.
Like for years when I was in the addiction service, we saw ourselves as the Cinderella service, like floating out there, because we were dirty service, because we had all these addicts and junkies and people who would rob your bag and stuff like that.
Oh, it's horrible,
there was like this perception. So it just needs to be brought into, like, we're part of primary care, can be anyone. And like when we do our overdose awareness day every August, on the 31st of August, we always have the tagline, it can be anyone's mother, father, daughter, son, friend.
Yeah.
It has no boundaries, overdose. It has no boundaries, drug use. So we just need to be mindful of that.
What are the services like outside of Dublin? Are they
improving all the time?
Okay.
Yeah, to give credit, improving all the time. We have to be very thankful to our community pharmacies out there who support that OST service, along with GPs out there. Around the country, there's quite a number of voluntary services who offer support services ancillary to, drug treatment. I know that in Limerick there's been a huge expansion of services with regards to a wraparound service for homeless populations as well down there. Similarly in Waterford and Wexford, huge kind of local services, having like nurses, doctors, local community pharmacists, all involved in offering treatment service. They don't necessarily have centralised service, like how in Dublin you have your GPs, pharmacies, and then you have your addiction treatment centres, and then you have the National Drug Treatment Centre. You don't have kind of that middle service down the country. The only place that has one now at the moment is Limerick.
Okay.
But there's no other one around the country.
There's also a drug use centre that's been opened up recently in Dublin, isn't there? Where they can go and use safely. Or is that
safe injecting facility? Yeah. That's not open yet.
Is it not?
No, that's mired in controversy with regards planning, etc., etc.
Is it near a school or something? And there's
correct?
Like,
yeah.
Okay.
No.
But no one wants it near them. So it's like that NIMBYism.
Yeah, but
do you remember Des Corrigan talking about NIMBYism?
But the only thing with it is that maybe we need to change its name to an overdose prevention centre.
Okay.
Than a safe injecting facility.
Okay.
Or a supervised injecting facility.
Yeah.
And equally, I believe that it should be a consumption room. If I'm a smoker of heroin, that I can go in and smoke heroin or cocaine. That it shouldn't just be down to injecting only. That's a very personal opinion. We should have gone for consumption rooms rather than injecting facility, I think.
And just also to explain the reasoning behind those facilities in general, because I know that
to use safely in intervention, it allows you to meet people who may never come forward for treatment. You might never see them for treatment. That they're in an environment where it's safe for them to use, and equally they can be shown how to use safely.
Okay,
and also be offered maybe overdose prevention. Piece like a naloxone, nasal spray or a naloxone injection.
And then potentially access treatment.
The whole idea, to give Ireland credit, our whole idea around all our harm reduction pieces is to signpost to treatment.
Yeah.
So when I did the pharmacy needle exchange program and was involved with the rollout of that, whenever we were recruiting pharmacists, it was never seen as a cold exchange, like, here you go, see ya. It was very much like, here you go. And the next time they come in, I'd encourage the pharmacist to engage with them, because you might have been the only person to say, how are you, to them. So a minor intervention could lead to, like, so the whole thing about make every contact count. So that contact might be enough for them to say something to you at another stage. Oh, Laura was nice to me yesterday. She asked me how I was. So the next time they come in, you'll go, oh, how are you today? I'm fine. I have a quick question for you. So suddenly you're opening up an intervention piece that, oh, I can't continue with this. I need to get into treatment. And then you're trying to signpost them.
Isn't it amazing that you said that you know, that you could be the only person that's asked them how
Yeah,
they
yeah,
are, and
yeah.
that has happened, and it's I think that sometimes healthcare professionals forget that.
Yeah, no, and the thing is that it's very powerful.
Yeah.
It's you could, you know, we use posh terms in it, like a brief intervention. Like that's what that is. That's a brief intervention. Okay, it's a very, very low grade brief intervention, but it's a brief intervention that you're asking somebody how they are. So
and it's also building up that trust with the person.
yeah, and also like they know that you're there offering them a service that otherwise, before the pharmacy needle exchange service, they'd have to travel the length and breadth of the country to get hold of fresh needles.
Okay.
So, for example, in where I'm originally from in Cork, they'd have to travel nearly all the way to Dublin. They'd have to travel all the way to Dublin to get fresh needles before the pharmacy needle exchange program.
Okay.
Now, services down there have improved, that they have now they can offer it down there locally from HSE services, bespoke needle exchange, as I called it earlier, pick and mix.
Yeah.
So, you know, things have moved on. So it is the cohort that comes in for needle exchange can be quite challenging cohort as well as for pharmacy. So, you know, there is a huge piece there, that there's a trust piece between the pharmacist and the patient coming in.
Denis, is there anything else that you'd like to say about addiction services, drug use, drug misuse, drug alternative use that we haven't explored today before I ask you my two burning questions?
Oh my God, too burning. I'm trying to think. I think that the National Drug Strategy is up for review. Its end year is 2025, I think. Now it could be 24, so I apologise. I should know it. And I would encourage people to get involved with the next strategy. It'll be interesting to see what comes out of this drug forum, that's the Citizens Forum, and who is going to that. I just wish it was more democratic how people were asked to go to it. So I know my dad in West Cork, 85-year-old man living on his own, got invited to sit at it. So he's never going to go to it, for example.
Okay.
You know, the random letters that were sent out to people. I think they need to have a mix of, so for example, cannabis, for example, you need to have a right mix of those who are pro legalisation and anti. Mm-hmm. So people get to hear to have opinions, that they hear both sides, that they're not weighed with kind of all of this, you know, bad, you know, that they also need to see there may be positives to certain things as well. So I think we need to be quite balanced in how that works, because I think that will inform our next strategy, is what I'm seeing. I'm always fascinated by how people are nominated to those things, and like there's some really good people on it, like Professor Johanna Ivers. She's amazing. I work with her to declare that. She's an amazing in Trinity. Really, has been around harm reduction strategies. Has worked in various fields. She's one that I know on it, that I would trust implicitly on it. But equally, maybe we need to invite in those who are on the fringes, who should be brought in to ask for their opinion. Like,
I definitely think so. I
think it would be really nice to know that our service users, the people who use our services, are going to be there. You know,
what's the chances of that happening?
To me, if you don't involve the end user in all of this, it's pointless.
Yeah.
They need to be somewhere in the mix. So I do think there's a great opportunity with that we should all feed into. The strategy is something that we should keep an eye on. I do think that from my perspective, and my pet project, I guess you could argue, is naloxone and overdose prevention, that everyone should be trained on how to intervene in an opioid overdose. that it should be like ubiquitous, that we see defibs across the country, AEDs, that naloxone should be in a similar vein.
Okay.
And I think that people need to voice what they want to say rather than saying, oh, you know, they should do this. Like, that's great. Sit on the sideline and say they should do it. You sometimes need to, if you want something to happen, you need to say it and use your power of the vote if elections come around, because aren't our local elections coming around? So people coming, ask them the questions. What are you going to do about this in our area?
Do you think, though, that people don't really care about it if it's not in their area?
Correct. Yeah.
So when you're not
You're back to your
seeing it,
NIMBYism.
Yeah.
But then it probably is there, but people don't like to talk about it.
Yeah. And as you said yourself, you know, you might see a person on the street who is homeless or in dire circumstances, and they may be a drug user of a certain type of opioid. But equally so, we have our housewife in leafy suburbia that could have just as bad a problem, but it's more hidden. Yeah.
Correct.
Yeah.
And that's the thing, like, you only find out things when you scratch at the surface. And like, if let's say there's changes brought in around, for example, over-the-counter codeine, what will that bring forward?
Yeah.
And only until... So it's a bit like when the Criminal Justice Act closed down the head shops. All those products went underground. So, for example, one of them was methadone, and we saw a spike in HIV rates because it went underground and we didn't see how much was being used.
Okay.
So that brought forward that we know methadone is a very powerful drug. It was really liked by a certain cohort. Weight loss was significant with it. Disinhibition was significant, hence the shared works and HIV. So we need to do an intervention then around these particular products. So, you know, you need to be adaptive, I think, as well as as organisations and as kind of healthcare professionals.
Doesn't that bring in that little phrase, with every action there is an equal but opposite reaction?
Correct, yeah.
So we can't just make, a blanket ban on something without actually thinking and having the foresight.
And equally, you can't do a blanket legalisation without thinking about everything. So.
Oh, touche. Dennis.
Good.
I'm going to ask you my 2 questions.
Okay.
Have you enjoyed the chat?
Yes, I have. Well, I always enjoy you, Laura.
This is definitely your thing. You know, your eyes light up talking about it. You need to, do more with it, I think.
Oh, yeah. Probably. Yes, yes. No, I still keep an interest in it. I do some work for some of the voluntary sector sitting on their boards. So, yeah.
I've always been hugely interested in it too. So anyway, Dennis, what advice would you give young people today?
Having 2 teenagers myself, I'm not very good at giving advice, I'll be honest with you. But what I would say to everyone is just be careful. If you decide you want to try something new, the consequence of it can be quite significant.
Okay.
When I'm in the addiction services, we used to always say to people that to do a taster, we just like to use a little amount to make sure it was safe.
Okay.
If people, like, I'm not going to ever judge anyone for using drugs, but please use them. If you're going to use drugs, use it safely and know what you're getting. It's really important, know what you're getting. There's lots of products sold out there that aren't what they are.
Yeah.
So to be very mindful of that, and to be very mindful that you can also say no to things, and to have the wherewithal around that to say no.
And the confidence to say no.
Well, it's very hard in a peer group and pressure to say, advice to young people. Like, I'm an old fella, so it's really hard to say. In my day, it was very much like, for me, it was the fear factor, like I remember the whole HIV epidemic hit when I was in college, and it was like, no sex. Okay, no sex, fine. Do you know what I mean?
Yeah.
So it's like, I know that people will always experiment, and that's all, like, you could argue me jumping out of an aeroplane in Zimbabwe, not having any health insurance was completely careless. Yeah, I did it, yeah. You know what I mean? Jumping off a bridge in South Africa was completely careless. Yes, it was.
Did you bungee jump?
Yeah,
off
so
the
it's like
bridge?
they were the things that so I did enjoy that. Would I do it now? Absolutely not. But that's called age and kind of and also kind of knowing the consequences.
Yeah.
In youth, the consequences are like you're living the here and now and enjoy it. If you have to experiment safely.
Okay. And Dennis, what is the meaning of life?
The meaning of life is...
Did you not read the text I sent you?
No, I don't read your texts.
I sent you a text saying, these are the two questions I ask
The
everyone.
meaning of life? Oh my God. God, the meaning of life, I guess, is living, isn't it?
Yeah.
Living, enjoying each moment. I think I think making every kind of thing you do count as something is really important. And also, I guess the other thing is that, to remember that it's... we said it earlier that for every consequence there's an equal and opposite, for every reaction, and to remember that yourself, that whatever you do in life, there's almost like we send out positivity to the world and positivity comes back. I know it sounds cliched, but it's so true.
It is.
I think trying to be positive in every situation. Sometimes things are very tough for everyone, but trying to maintain a positive outlook, I think, is the most important thing. And to live and enjoy your life, because you get one chance.
I love it. Dennis, it's been a pleasure. Thank you so much for coming on.
No problem. Thank you, Laura.